Good evening, everyone. My name is Amy Wood, and I'm the Executive Director of the Raymond A. Wood Foundation. Thank you so much for joining us this evening. We're so honored to have Dr. Lisa Swartz Topor here with us this evening to talk about cortisol replacement. Dr. Topor is the Fellowship Director of Pediatric Endocrinology at Rhode Island and its Hasbro Children's Hospital, and is an Associate Professor of Pediatrics and Teaching Scholar at the Warren Alpert Medical School of Brown University. She is board certified in pediatrics and pediatric endocrinology, and her clinical interests include adrenal disease, thyroid disorders, and diabetes. Dr. Topor received her medical degree from Harvard Medical School in Boston and completed her residency and fellowship at Boston Children's Hospital. She pursued additional training and clinical investigation at Harvard Medical School and Massachusetts Institute of Technology. Thank you, Dr. Topor, for being with us tonight. Just a few housekeeping things. Many of you have been to our webinars before, and some of you are new, so welcome. During the discussion, we just ask that you submit your questions using the QA feature at the bottom of your screen. You can also choose to upvote questions already in the QA feature that you like. You may also put your questions in the chat section. Just make sure to set the two fields to panelists and attendees. When Dr. Topor is finished with her presentation, she will start answering questions. We do also have a poll feature which will be launched, and we encourage you to take part so we can share the results during the session. Without further ado, I'm going to turn it over to Dr. Topor.
Thank you so much for the introduction and for having me join you guys this evening. Let me get my slides up. All right. And so I'm going to be speaking about central adrenal insufficiency, and I'm going to go through sort of the basics and really focusing on the medications and optimizing replacement. And I look forward to hearing the questions at the end of our session. So as was mentioned, please put forth the questions into the Q&A or the chat section, and we'll get to them at the end. So tonight I'm going to talk about some basic definitions. I'm going to go through the hypothalamic-pituitary adrenal axis, because unlike some of the other axes of the endocrine system, this one is quite interesting in terms of the day to night variation hormone production. I'm going to talk about some of the symptoms of central adrenal insufficiency as well as the treatment. So when we talk about adrenal insufficiency, we're talking about the adrenal gland, which is a almost triangle-shaped gland that sits above the kidneys. There are two of them. And insufficiency, meaning there's not enough of the hormones that the adrenal makes. And when we talk about central adrenal insufficiency, we're talking about a problem that's due to the dysfunction of hormones from the hypothalamus or anterior pituitary glands, the hormones that control the adrenal gland. So we have the anterior pituitary gland that makes, amongst many other hormones, a hormone called ACTH, or adrenocorticotropic hormone. You see why we use the abbreviations. And that is what tells the adrenal gland to make cortisol. Above the pituitary gland is the hypothalamus. And also the hypothalamus is responsible for a variety of functions, including hormone production. It makes a hormone called CRH, corticotropin releasing hormone. And so when we talk about central adrenal insufficiency, we're really talking about either a problem at the hypothalamus and the release of CRH, or the anterior pituitary and release of ACTH, or both. The term central adrenal insufficiency is also called secondary, meaning a problem at the pituitary, or tertiary adrenal insufficiency. But for the purposes of this talk, we're really going to be calling it central adrenal insufficiency. So putting it all together, we have the hypothalamic, at the base of the brain, the hypothalamus, the pituitary directly beneath the hypothalamus, and the adrenal glands sitting on top of the kidney. And these are the problem in the central system would be somewhere up here, even though the adrenal glands are all the way down here. And my schema for this, drawn out, we have the hypothalamus releasing CRH down through the pituitary stalk, which acts on the anterior pituitary. The anterior pituitary releases the ACTH that travels to the two adrenal glands and tells the adrenal gland, or signals the adrenal gland, to produce cortisol. That's the main hormone of interest in terms of thinking about central adrenal insufficiency. But as I'll mention in a few minutes, not the only hormone at play. The cortisol in a functioning system has a negative feedback, meaning that as the cortisol levels rise, there's a signal sent back to the anterior pituitary as well as to the hypothalamus that tells these systems that you don't need to make as much CRH or as much ACTH. And that way, if cortisol levels are high, the signals to produce more cortisol are shut down. And when cortisol levels are low, the signals are turned on to make more cortisol. And that's a functioning feedback loop. So the adrenal gland itself, and again, there's two of them, has an outer layer called the cortex, where aldosterone is made. Aldosterone is the hormone responsible for sodium and potassium balance, and it is not affected by the ACTH system, and it is not affected in central adrenal insufficiency. If there's a problem directly with the adrenal itself, there will be insufficient aldosterone production. But again, in central adrenal insufficiency, aldosterone production is regularly produced and regulated. The cortisol, the main hormone, is a problem with central adrenal insufficiency. And then the adrenal androgens, which are also made in the adrenal cortex, are deficient in the setting of central adrenal insufficiency. In addition to the outer layer of cortex, there's an inner layer of the adrenal gland called the medulla. And the medulla is where the hormones epinephrine or adrenaline and norepinephrine, noradrenaline are made. The medulla is a neuroendocrine tissue. And though the regulation of epinephrine and norepinephrine are not regulated by ACTH or any of the hypothalamic or pituitary hormones, the production of these hormones in normal amounts requires adequate cortisol production from the adrenal. So it means that in the setting of any form of adrenal insufficiency, if there's a problem with cortisol, the medullary production of epinephrine and norepinephrine is also diminished. And that comes into play when we think about what happens in the setting of adrenal insufficiency. It's not just the cortisol level that is low, but it's also the response and the body's ability to make adequate amounts of adrenaline or epinephrine. So cortisol, the main hormone that the adrenal makes that we're going to be talking about. So it is essential, and it's controlled by ACTH, and it is produced in a circadian rhythm with the highest levels in the morning and the lowest levels at night. And it is not responsible for any one thing, but it's very involved in the regulation of many things in the body. And that includes the stress response, when the body is physically stressed with illness or with in response to surgery or a broken bone. Cortisol is responsible for helping maintain blood sugar levels, keeping them at a high enough level for normal function. It's involved in metabolism and the use of the body's fats, proteins, and carbohydrates that are stored. Cortisol also suppresses inflammation, and it's involved in the regulation of blood pressure. So again, there's no one thing it does, but it does a lot of things, and it's involved in a lot of things. So this circadian rhythm, this is taken from a publication monitoring one person's ACTH levels, so that's the pituitary hormone, and the cortisol level. 8 in the morning is here, and then noon, 4 o'clock, 8 p.m. And as you see, the levels are high in the morning and drop down through the day. And then somewhere between 9 p.m., midnight or so, there's a lowest level, and then it slowly begins to rise up. Both the ACTH levels and the cortisol levels have a high and then a low, and then they rise up in the wee hours of the morning. I simplified this and sort of made an artistic rendering of it. The darker blue is the ACTH level, highest in the morning, drops lowest in the evening, late evening, and then rises up again. And following that, cortisol, which is dependent on the ACTH, highest in the morning, lowest at night, and highest in the morning again. And this happens every single day, day in and day out. And of all the hormones the body makes, this has the widest variation day to day. And in order to have cortisol do all the things that it needs to do, the body needs to see a big amount of cortisol in the morning and really doesn't need to see much cortisol in the late evening, midnight hour. And in fact, if there's too much cortisol around late in the day, that can cause some of the side effects we associate with too much cortisol or too much hydrocortisone. So again, this diurnal rhythm is really important for cortisol, as well as for just overall wellness as it relates to cortisol. So when we have this beautiful feedback loop and we think about our intact axis, every morning, high amounts of CRH to ACTH to the adrenal gland, making lots of cortisol. every midnight, low levels of CRH, low levels of ACTH, and low levels of cortisol. When there's a partial deficiency, meaning there's not a normal CRH production, but there's some, you could have some cortisol, not a diurnal rhythm, not meaning high in the morning, low in the night, but enough so that you have some cortisol production at all points of the day. Whereas if you have not any function, such as if there's been a problem with the pituitary gland being removed, or in terms of when it was during formation, if there's not normal formation of the pituitary gland or some of the specific cells involved in making ACTH, or if there's surgery or injury that transects or cuts the pituitary stalk, there can be an absolute deficiency, meaning there is no production of ACTH, there's no cortisol production at all. And this comes into play when we think about how we're replacing the cortisol. Does somebody need cortisol every single day, or do they need it only in very stressful situations? And in part, that has to do with where is the problem and what's the nature of the problem. So when we think about central adrenal insufficiency, how common is it? Well, in data from Europe, it's reported in about 15 to 30 individuals per 100,000. And this includes both isolated ACTH insufficiency from either genetic forms, as well as from tumors or surgeries or injuries, or a combination with other pituitary hormone deficiencies. In terms of thinking specifically about craniopharyngioma, when one is looking at outcomes in terms of how patients do, quality of life is frequently a challenge in many long-term survivors of craniopharyngioma or other forms of hypothalamic tumors or hypothalamic surgeries. And that's mainly due to the neuroendocrine problems. And how those problems manifest, how they show, is really based on the location of the tumor in terms of how close it is to the hypothalamus, and pituitary gland. So when we think about endocrine hormones and craniopharyngioma specifically, in terms of initial presentation, there's often non-specific manifestations of intracranial pressure, meaning headaches and vision symptoms, or patients can present with endocrine deficits. And according to the literature, more than half of patients will present with endocrine deficits before or at the time of diagnosis, before any intervention have been made. And when closer looks have been done, looking at which specific hormones are involved, about 25% of patients at the time of diagnosis have some evidence of ACTH deficiency. So certainly not as common as growth hormone deficiency or growth hormone insufficiency at diagnosis, but also not rare in terms of how patients come in. And when we think about the hypothalamic neuroendocrine dysfunction seen in patients with craniopharyngioma at the time of diagnosis, and the reason I bring this up is because you'll see some of these symptoms can also be related to too much cortisol replacement when we come into treatment. That's why I want to bring up this topic. So in about a third of patients with craniopharyngioma at diagnosis, there are reports of obesity, behavioral changes, disturbances in the circadian rhythm or sleep-wake cycle, daytime sleepiness, as well as imbalances of body temperature, of thirst regulation, heart rate, blood pressure. And then after surgery, and based on where the surgery takes place and how much of the hypothalamus is involved, the neuroendocrine dysfunction can be in 2/3 to 80% of the patients. So the hypothalamic neuroendocrine dysfunction is quite common in folks who have craniopharyngioma, and certainly after surgery. So in thinking about how we treat cortisol deficiency, we talk about cortisol or steroid replacement. So just for me to get a sense of the audience, I have a poll here for what type of steroid replacement has been prescribed to your child or to you if you're the one who's taking these medications. So it looks so far that everybody who's on steroids or whose child takes steroids is on both a daily plan and a stress dose plan? And I see also the second question. I'll talk about more about the different formulations of how hydrocortisone is given. All right. Any last folks want to take the poll? All right. So it looks like everyone who answered is talking about both maintenance and stress dose steroids when we talk about giving back cortisol. I'm going to close out the poll. All right, so let me talk for a second about adrenal insufficiency. So the symptoms of adrenal insufficiency are often nonspecific and insidious. They kind of can creep up on you and be very, very subtle and not really identify themselves as adrenal insufficiency until they become very obvious. And they also can be due to many other things. Things like fatigue, weakness, unexplained weight loss, reduced appetite and nausea, particularly in the mornings. And then if the cortisol deficiency is really severe, there can be low blood sugars, particularly after prolonged fasting. But I have some patients that had headache as their main complaint or leg pain. So even though the textbooks will give you certain criteria, how different people present really varies. And so knowing what the symptoms are for each individual is really helpful when we're figuring out how someone's doing with their cortisol replacement. So patients with adrenal insufficiency are going to require glucocorticoid replacement and some mild forms, the forms in which there's some mild hypothalamic dysfunction with the CRH, but enough cortisol from day to day to not require daily cortisol replacement can be seen. These are folks who only require stress dose, and I'll get to the definitions of what stress dose is soon. But when we think about stress, and that's when the body needs more hydrocortisone or more cortisol, all patients who have any form of adrenal insufficiency are at risk of an adrenal crisis and require more cortisol or more hydrocortisone at all ages. So the most typical form of replacement that my patients have as well, like the audience here, is both requiring daily hydrocortisone as well as stress dose hydrocortisone. But I do have a few patients that just need stress dose hydrocortisone because they're able to make enough day-to-day cortisol. So when we think about why replace glucocorticoids, it's not just about the sort of pieces that I was describing before about what cortisol does and how it helps with all different aspects of metabolism, but it actually, in studies that have been done, makes a difference in quality of life. Missed or delayed replacement doses can reduce well-being and even bring on an adrenal crisis. And optimal treatment adherence is associated with a better quality of life in patients with adrenal insufficiency. And so missed doses for anyone who has teens or young adults, that's a population in which missed doses can occur more frequently for a variety of reasons. Sometimes as adults transition into more independence, there can be financial and psychosocial factors, including housing insecurity, that get in the way of being able to take medications daily. Sometimes there's diminished access or interest in accessing medical care. Sometimes with teens, there's social pressures to keep the diagnosis a secret. So taking out a little pill bottle and taking medications at different times of day might be something they don't want to do. And sometimes patients get the idea that too much hydrocortisone is causing weight gain, so they'll reduce doses or they'll skip doses to reduce weight gain. And all of these things really have a negative effect on quality of life. So when we approach treatment of central adrenal insufficiency in childhood, we really think about matching what the body needs, a physiologic replacement. And if clinically stable, most clinicians are going to replace the daily dose with a low dose. And the reason why we are really focused on a low dose, especially in childhood, is that replacement of glucocorticoids can complicate attempts to optimize stature. Too much cortisol, too much hydrocortisone can slow your height growth. And over replacement of glucocorticoids can also lead to increased weight gain. So with any patient, but especially patients who might also be on growth hormone and might also be struggling with excess weight gain, we really want to walk a fine line between giving enough glucocorticoids to allow for wellness and quality of life and avoidance of any symptoms of adrenal insufficiency, but not too much that we're going to interfere with stature or that we're going to lead to increased weight gain. The stature piece is only a factor in growing children and teens. Once height is completed and into young adulthood, that's not as much of a concern. And then we have stress dose coverage. And again, I bring up this figure again and again, you'll see, to remind us that we're really trying to optimize and replace this daily circadian rhythm. So when we think about maintenance or daily glucocorticoid doses, we think about them in amount 8 milligrams per meter squared per day. So that is how much the adrenal gland makes. When we measure how much cortisol in a healthy adrenal gland makes, it's about 8 milligrams per meter squared, which is a measurement of the body size per day. And it's important to adjust this now for individual need. There can be marked differences in both how quickly the body metabolizes cortisol, as well as how quickly it absorbs when we take cortisol by mouth. And we really want to avoid doses more than 17 milligrams per meter squared per day, because that's when you start running into trouble with growth and side effects. And so what does meter squared mean? And I give this to you not because I expect anyone to do the calculations, but it's really helpful to have a sense when doctors and other providers are calculating doses to figure out, like, what is it we're doing? And so body surface area, which is measured, it's meters squared, it takes into account the child or the adult's height, their weight, and then divided by 3,600, which is fixed for everybody. And so as an example, we have a 12-year-old boy, 5 feet tall and 145 pounds. So first converting that into centimeters and kilograms. And then we're going to plug those numbers right into this formula. So we take the kid's height and we take the weight in kilograms, we divide by 3,600, and we do the square root function of that. So it's 1.67 meters squared. And why does this matter? Why is this helpful to know as a parent or as an individual or caregiver? Because as the kid grows, as their height increases or as their weight increases, or both in many cases as kids are growing, this meter squared number is going to go up and the dose is going to go up. So if it's 1.67 meters squared per day, that's 1.67 meters squared is the child's body surface area, and we want 8 milligrams per meter squared per day, we take 8, we multiply it by 1.67, and that gives us 13.4 milligrams per day. That would be a starting dose. And then we divide that up throughout the day to match what the adrenal gland does. So again, it's just helpful because when I find it's almost like a foreign language sometimes when these numbers are calculated, but it's all based on a formula and using height and weight in it. And so during growth and puberty, higher doses and more frequent doses might be needed at times because of all that activity that's happening during growth and during puberty. And the other reason why we see our patients so often, especially during these growing active years, is because we need to review the doses, look for side effects, recalculate the body surface area to meet the demands of rapid growth in puberty. And then the other question I had, and I know we had already answered it in the poll, was talking about the daily steroids, which everyone had said that they or their child was taking. And it looked like almost everyone, 80% were doing it twice a day for hydrocortisone, and few of you, two folks reported on doing hydrocortisone 3 times a day. So when we think about adrenal insufficiency, the first piece is do not overtreat. And the best medication for growing children and adolescents is hydrocortisone because it's short acting. It's harder to overtreat when you have something that's going to wear off quickly. The downside is that there's often multiple daily doses, and remembering to take them all and take them at the right time can be really challenging. In adults, sometimes the transition is to prednisone, a longer acting glucocorticoid. And the benefit is that it sometimes can be given once daily in the morning or sometimes twice daily. The downside is that any of the longer acting formulations can have negative side effects of the glucocorticoids. And finally, dexamethasone is a very potent and very long lasting glucocorticoid with a really high risk of excess glucocorticoid side effects. So we really try to avoid using it unless there's a lot of challenges with the other formulations of glucocorticoids. And when we're thinking about how to dose hydrocortisone, some just general starting points. And again, we use this, meter squared calculation, but just to get a sense of what a big child, a small child, an adult would take. A small kid would take maybe 5 milligrams a day, divided the biggest dose in the morning and then 2 smaller doses during the day. A bigger kid might take 10 milligrams total during the day, divided as a big dose in the morning and a smaller dose in the afternoon, or a bigger dose in the morning and 2 smaller doses in the early afternoon and early evening. So I'm going to go back to this circadian rhythm figure. I'm going to take out the ACTH piece because we're really only interested in cortisol. And really, when we think about what we're doing when we're replacing hydrocortisone, we're replacing cortisol with hydrocortisone. So we want to match this. We want big doses in the morning, and we want almost nothing in the system at night. And so when I am taking care of a patient and I'm trying to match this, I'll take the hydrocortisone and dose it out early in the morning with a big dose, and maybe a smaller dose in the afternoon and a very small dose around dinner time. And we really want to not have anything in the system around midnight or so. So this normal drop down in the circadian rhythm can happen. And so when we think about and then we give another dose in the morning. So when we think about what the hydrocortisone is doing, we're really trying to match this cycle each day. And you can see why if the hydrocortisone, the first dose, if the child sleeps in and takes the hydrocortisone later in the day, you can see you might miss this early morning peak, and that might lead to some morning fatigue or nausea or headaches in the morning. And similarly, if they take the dose way later at night, you can imagine that instead of having this real drop down at night, the level of the hydrocortisone might not be as low as what the body needs, and there might be side effects of having too much cortisol in the system at night. When people take prednisone, which again, we don't use often in children, but sometimes it is used in adults, especially when taking medication 2 or 3 times a day might be a challenge, especially on top of other medications as well. Prednisone you can give once in the morning, and the challenge is that as it falls, it doesn't often fall enough so that you have too much cortisol or too much glucocorticoid in the system late at night, and that's going to cause those side effects. And similarly, with the long-acting dexamethasone, it's really hard to match that circadian rhythm. And that's when we really see the side effects of excess glucocorticoids or excess steroids, is when it's sticking around 24/7. So what are the impacts of too much glucocorticoid? And I want you to think back to that earlier slide where I was describing some of the neuroendocrine symptoms that are seen after craniopharyngioma or craniopharyngium surgery or any other surgery that's going to disrupt the hypothalamus. Weight gain can occur when there's too much glucocorticoid, a slowing of the height growth, insomnia or sleep dysregulation. Cutaneous infections can occur, and that's often fungal infections like yeast infections. Muscle weakness can occur. Dark purple stretch marks and easy bruising, and that's because of tearing of the inner layers of the skin, as well as glucose intolerance on the path to increasing your risk of diabetes. And even subtle overdose in terms of that daily dose of hydrocortisone really predisposes to many of these complications, including the obesity and type 2 diabetes, as well as low bone density in the long term. And again, the ones in red are also signs of neuroendocrine dysfunction. So teasing out what's going on with a patient who might be at risk for both neuroendocrine dysfunction and excess glucocorticoids can be a challenge, and really requires a closer look and a lot of patience as thinking about adjusting doses and adjusting timing of doses to see if we can alleviate symptoms and also treat the patient adequately. So when we think about how to optimize these daily steroids, some people report poor stamina, fatigue, headache, or tiredness only at certain times of the day. And is this related to insufficient cortisol just at that time of day? So I find that changing the timing of the doses, ideally, and it's really sometimes a challenge, especially with teenagers, to as early as possible in the morning, even 2 to 3 hours before getting out of bed, especially if someone sleeps in, can really help with early morning symptoms, whether they be headache or real extreme fatigue in the morning or nausea and lack of appetite. And sometimes dividing into frequent smaller doses can be effective. Sometimes there's a lull around 3, 4 o'clock in the afternoon, and sometimes adjusting a dose so that there's a noon dose and a 4 p.m. dose can make a difference. And sometimes it's not about increasing how much we're giving total in the day. It's about shifting around the timing of the doses or stretching it out a little bit and dividing 2 doses into 3 to see if that helps with symptoms. And then new to the market for our youngest patients, the pill sizes might not be the right size for them, and they might need really small, precise dosing. One of the challenges is that unless it's a reliable compounding pharmacy, liquid hydrocortisone formulations can be somewhat unreliable. And so in the setting of lack of having a good compounding pharmacy, we're stuck with pills. And so the Alkindi sprinkles, which were approved about less than 2 years ago, have really small doses of hydrocortisone down to 0.5 milligrams. And so these capsules are opened up and either sprinkled on food or sprinkled directly into a small child's mouth. And this really has helped us when we have the youngest of children with adrenal insufficiency who need very precise dosing and very small dosing, but we don't have the capability to give them a liquid formulation. So now on to adrenal crisis. So an adrenal crisis occurs in response to acute stress. And the top cause of adrenal crisis, certainly in the pediatric population, is going to be an intercurrent illness. And it's not only a cause of an adrenal crisis, but it's actually one of the biggest causes of excess mortality in patients who either have hypopituitarism or even those who just have isolated adrenal insufficiency. And so adrenal crisis is not rare. Studies out of Europe show that it occurs. One study of the UK shows it occurs in 8% of patients who have adrenal insufficiency per year. And 1/3 or nearly 1/3 of a Japanese study with adrenal insufficiency had experienced adrenal crisis. And one study of Germany showed that 7.4% of patients had at least 4 episodes. So is there something about certain patients that makes them more at risk of an adrenal crisis, whether it's something about their physiology or something about their medications that sets them up to be more at risk? So what are the symptoms of an adrenal crisis? Lightheadedness or dizziness, weakness, often abdominal pain with nausea and vomiting, low blood pressure, and loss of consciousness. And these can present rather quickly in the setting of a stressor like illness. And as I mentioned, infection's a major trigger of this. And it's because cortisol, well, first of all, plays a big role in the immune response. So without cortisol, there's a tendency towards more inflammation. So when the body is experiencing an infection of any type, and there might be some inflammation going on, normally when the adrenals are functioning, cortisol levels will rise and suppress some of that inflammation. Well, the lack of that excess cortisol will allow the inflammation to increase further, which can lead to lower blood pressure and reduce the blood circulation. The stomach bug, certainly in the literature and certainly in my own patient population, is the most common trigger for an adrenal crisis, especially in the youngest of children who have much less reserve in their body. Vomiting and diarrhea can cause dehydration and throw off the salt and water balance. Additionally, vomiting will make it very difficult to take any medications by mouth, and diarrhea can decrease the absorption of the glucocorticoids, of the hydrocortisone, when it's after it's taken. So even if it goes in and stays in, it might not be absorbed as well. And so the body is not seeing as much cortisol as it needs. So what are the other triggers of adrenal crisis? So fever, the abrupt withdrawal of glucocorticoid therapy, so missing doses, failure to provide the appropriate glucocorticoid coverage for surgical procedure, because that's another major physical stress, a fractured bone, or any other major physical stress. What I tell patients, it's not the stress of getting in a fight with a friend. It's not the stress of being really nervous for an exam, but it's something really physically affecting the body. And so how do we prevent an adrenal crisis? So it's recognizing possible triggers and preparing a sick day plan, and as well as reducing the risks of serious illness. So things that we could do to reduce the catching of illness and how sick we get from illnesses, like routine childhood vaccinations. And so adrenal insufficiency during illness. So what can we do to help reduce the risk of an adrenal crisis? So one thing is to avoid dehydration, providing adequate fluids as well as sugar, and a low threshold to seek hospital care if it seems like the fluid losses, either through vomiting or diarrhea, are greater than the intake. So even if this means drinking a half an ounce of liquid every few minutes and making sure that liquid has sugar in it to stay hydrated. But being really ready to go and seek care if it just seems like a kid is too tired to keep up with that, or the vomiting is just too much to keep up with that. And then stress dose steroids. So that's increasing the hydrocortisone dose by mouth for starts up to a maximum of 50 to 100 milligrams per meter squared per day. Often this involves doubling or tripling the daily dose. For my patient population, I tend to just prescribe a fixed dose so that there's no sort of math calculations and doubling or tripling doses, and just saying this is the stress dose and give that dose. But there are many ways to do it, but it just means your body needs more steroid than it does on a daily basis. And then if the child can't, or an adult can't take hydrocortisone by mouth, or if there's significant diarrhea that the medications aren't being absorbed, giving the hydrocortisone in another form, which at home can be done by injection. We use often use the hydrocortisone active vial or Solucortef active vial. And so what we're trying to do when we have oral stress dose is we're giving large doses of hydrocortisone every 6 hours. And this is going to allow that hydrocortisone or cortisol level to stay high through the day and really be above the normal daily peak 24/7. And we prescribe this every 6 hours. And I ask patients to continue taking their medication for at least 24 hours until the illness or stress resolves. And then they could return to their daily maintenance hydrocortisone. So the Solucortef active vial, there are lots of YouTube videos on how to use this, but I wasn't tech savvy enough to embed it into my talk. But there's a liquid component and powder at the bottom. And we teach our families how to use this, and we practice doing it in our clinic, not the injection part, but the pushing this down, pushing the water into the powder section. And then the little orange rubber stopper will end up at the bottom here of the powder. And it dissolves very easily. It will swirl very easily until it's clear. And then the top is taken off, this yellow top is taken off. The stopper is wiped clean with alcohol. And then a needle is pushed into the vial, and then it's flipped upside down and the medication is withdrawn. And the vial contains 100 milligrams of Solucortef, which is the entire dose is given for a adult sized person. And we often recommend portions of that depending on the size of the child. But I always tell families that if you're super stressed out and worried and you forget how much to give, even if you give a small child the full vial, they will not be hurt by it. And even if you give the child this medication when you're like on the fence, should they give it, should they not give it? One dose of this is not going to hurt anybody. This is a medication that is relatively short acting, but it does what it does if it's needed. So I'd rather have families err on the side of caution and give it when they're unsure. So that's the advice I give to my patients. And so hospital level care. So if you can't manage it at home, if there is too much fluid loss, if there's too much vomiting, if a kid isn't, or an adult isn't awake enough to take medications or drink enough by mouth, they need to be in the hospital. I also tell my patients' families that if they need to give the Solucortef injection, they need to come to the hospital. They need to be checked out. What happens in the hospital is that the lower blood pressure or even shock can be treated with IV fluids, which is going to be normal saline to provide both fluid and salt. And then low blood sugar, because cortisol also raises your sugar levels, will be treated with dextrose through the IV. And then patients are given hydrocortisone through an IV as well, given continuously or in repeated boluses through the day. And then as the illness resolves, the patients can return to their maintenance hydrocortisone regimen over the course of a few days based on how they're doing. So one of the other things in terms of prevention and hospital care is the medical alert bracelet. And this allows quick identification that stress dose steroids are needed. In the setting of central adrenal insufficiency, people often ask, do I have to explain what form of adrenal insufficiency it is? In the setting of a true emergency, when the goal is get steroids into the body, get that hydrocortisone into the body, it doesn't matter in terms of conveying what type of adrenal insufficiency is going on. And my advice to patients is to just say they have adrenal insufficiency, they need stress dose steroids. And those are the words to use in the ambulance or to a hospital. And then the details about what type of adrenal insufficiency and what are the nuances of it can be explained later, but it's stress dose steroids is the first thing that must be done. If we go back to when I was describing what does the adrenal do, I mentioned it also makes androgens. So androgens are the hormones like testosterone that cause some of the secondary sexual hair in the body. Patients with ACTH deficiency also have androgen deficiency. Now, in individuals who are going to go through male puberty, and they'll either make or receive testosterone, the testosterone is going to provide more than enough androgen. In women, there is often a lack of secondary sexual hair when there's adrenal insufficiency. There's also some questions about whether androgens are playing a role in libido or in mood in women with adrenal insufficiency. But there's really not great long-term data on replacing androgens, and these sort of official guidelines are not to replace routine androgen replacement in those with adrenal insufficiencies. The only place it's being done, at this time is really in the setting of clinical studies. So it's something that comes up and is sometimes asked about, but at this point in time, the risks of treatment or the unknowns of treatment outweigh the benefits. And then in terms of practical considerations, there's no evidence that shows that extra dosing of sort of the daily hydrocortisone improves physical activity, but many patients report a need for extra dosing depending on what type of stressful situation they're in. I'm not talking about a stress dose, just more like an extra daily dose. Sometimes with unaccustomed exercise or a race or a big sporting competition. One example is one of my patients has adrenal insufficiency and plays soccer at the collegiate level. And so before a very big game, she'll often need an extra 5 milligrams of hydrocortisone, bigger than her daily dose at that time of day, and really finds that makes a difference for her. Also, patients who work a night shift need to adjust their over time, not the first night, but over the time, their circadian rhythm will switch, and their cortisol levels would naturally be highest at the start of their wake-up time, even if that's not at 6 a.m. And so they might need to switch the timing of their hydrocortisone so that biggest dose is when they first wake up and start their day. And then one last thing, medications that can impact cortisol and hydrocortisone metabolism. So certain medications, particularly a few seizure medications, can accelerate or speed up the metabolism of cortisol, as well as hydrocortisone. And that if a patient or a child is taking these medications, just to consider that, and that they might need more than the typical dosing. And similarly, a few substances can slow the metabolism of cortisol. One of them is the plant that licorice is from. We're not talking about Twizzlers or the stuff you buy at the candy store, but real licorice, which is glycyrrhizic acid is the substance. And that could slow cortisol metabolism, as can a lot of grapefruit juice. So just to think about the extra things that might be playing a role in our hydrocortisone or cortisol metabolism. And so just in summary for this part of the talk, the key points that I really wanted to focus on for glucocorticoid replacement goals, for the maintenance, we really want to be cautious because the over replacement of the everyday dose can lead to increased weight gain and or slowed growth. And at the same time, lack of physiologic replacement, lack of enough replacement can really impact quality of life. And so when trying to figure out, do we need more, do we need less, what's a side effect, what's something else, really small changes and frequent reassessment, adjusting doses, adjusting timing of doses. And then with stress dose, early treatment is essential with oral or injectable glucocorticoid. And a one-time or a two-time stress dose is not going to cause the long-term side effects in the short term. So really, the daily dose, we want to be as cautious as possible. But when it comes to the need for stress dose, we really want to be aggressive and say, okay, does this child need stress dose? Let's give a dose and see, is it going to become a fever? Are they going to throw up? And getting that extra stress dose on board first, as soon as there's any concern for any potential adrenal issues, and then reassess. So again, big on the stress dose and small on the daily dose. And that is the end of my formal part of the slides. So now I'm excited to hear what questions have come up while I've been talking.
Thank you so much, Dr. Topor. And we do have a few questions, so we'll just kind of run through them. We had one question that came in at registration, and she asked, my daughter has been on cortisol for 16 plus years. What are the long-term effects?
So the long-term side effects of cortisol really have to do with the dosing and if the dosing is physiologic, if it's matching what is needed. So if you're really following that daily circadian rhythm and the doses are just what's needed, it would be the same as if the body is making hydrocortisone, and we really don't expect to see side effects. When the doses are higher than what's needed, that's when we think about the impact on the bones, because high amounts of cortisol, like excess amounts, meaning more than what's needed on a day-to-day basis, can have impact and lead to lower bone density. Certainly obesity can occur, especially if you're not having that low amount overnight. But again, if somebody has been, had their doses adjusted as they've grown and they are on the appropriate amount for their size and their needs, I don't think of this in the same way as someone who's on excess cortisol, excess hydrocortisone for other things. And when we think about other medications or other things that are used, people who take prednisone, for example, for inflammation, for rheumatoid arthritis or asthma, those are in much, much, much bigger doses than these hydrocortisone doses every day. And so we really don't expect to see the same types of side effects that you might see in other populations.
Great, thank you. Okay, so next question's from Grace. She asks, is slow release, modified release hydrocortisone recommended, or is it harmful?
So that's been sort of one of the holy grails of hydrocortisone is, can we get a formulation that you can take, if you think about that, when I was showing the graphs, that rise up happens so early in the morning. Can we find a formulation that gives us a big amount at like 4 or 5 in the morning and then drops down? It's really too soon to say. There's been a lot of research done, and it's just coming out as sort of the different formulations and how they work. So I think it's as long as the hydrocortisone is matching what the body should be doing, I would expect it to be really well tolerated. But again, there are different adrenal disorders that require different amounts of hydrocortisone at different times of day. And so this whole talk, I was talking about central adrenal insufficiency. There are other adrenal problems that you might need more in the night. And some of the extended release formulations are designed for other primary problems. So it's really something specific that that we need to look into, because I don't think that any of the extended release formulations have been looked at in the central adrenal insufficiency population. So I think there's more to learn and more to come on that topic.
Okay, great. And I know you said that hydrocortisone is short acting, but how short? How long does a dose last? And you may have touched on that, but if you can reiterate, that would be great.
Yeah, so it has the shortest half-life of all of the different forms of glucocorticoids. And generally, we think of it lasting around 6 hours. And that's why we stress dose hydrocortisone every 6 hours. And again, if you think, every individual has a different rate of metabolism and different absorption of cortisol, or hydrocortisone. So it's not an exact amount or exact timeline for every single person. But if you think about roughly it lasting 6 hours, that's a good sort of starting point or rule of thumb.
So with that said, what would you say the timing would be of the last dose in the evening? What do you usually recommend? So
usually you want there to be really like a nice drop down somewhere around midnight or so. So a last dose somewhere around dinner time. And again, it depends on what time the child goes to sleep and what the rest of their day and their night looks like. But again, everyone's different. And so some folks might say that their kid gets really hyped up and really wired if we give them a dose anywhere near bedtime. And so maybe we pull it back by an hour. And again, I think, what I've learned in taking care of lots of different patients at different times of their lives is start somewhere and then adjust in small amounts really carefully and reassess. And sometimes, an hour difference makes a difference for the patient. That's the right time then for them.
Yeah, okay. On the subject of the pump, any thoughts on research on the cortisol pump, and is it something that would be relevant to our audience?
Yeah, so work has been done in in looking at small continuous amounts of hydrocortisone, basically using the same technology that's used in insulin pumps. In some ways, it's a great idea because then you can really, really exactly map out that same up and down every single day. You could time it perfectly and really tailor it to your individual, your child's needs. Again, not ready for prime time. The formulations of hydrocortisone staying, in solution in the pump and how much is delivered. The pumps are given subcutaneously. So there's a lot of potential, a lot of promise as our technologies in general get better, and our pharmacologies get better. I think there's a lot of potential here. The flip side to that, though, is that pumps can get disrupted. And so if the pump site falls out, and again, we deal with this with patients with diabetes on insulin all the time, but it just adds another level of, there's always a pro and a con to things. Mm-hmm. So it's in the area still of research and under development. But I think that there might be a role. I also think that there are other, like I was mentioning, other forms of adrenal dysfunction that require very different types of regimens. And so a pump would allow really tailoring it to any individual's needs. So there's a lot of potential there.
Great. Looks promising. So next question is, we have been told that the patients should always take hydrocortisone with food, but since many CP patients are also on synthroid, which needs to be taken on an empty stomach, what would you advise about timing and dosing of these two medications in the morning? It's a good question.
Yeah. So in general, with the low dose, the daily dose of hydrocortisone, I feel less strongly about it being given with food. The challenge also is that when it's a higher dose, the stress dose, then they're often nauseated. It's really hard to give that one with food too. So I'm a little bit I feel much more strongly about taking Synthroid or levothyroxine without food than I do with hydrocortisone with food. If you're going to have to pick one, at least that's what I advise my patients. And, for patients that a parent might be waking them up at 6 a.m. to give them their levothyroxine and hydrocortisone together first thing in the morning so that it could get in before the child gets up, before you have to go through the breakfast and starting the day routine. Taking them together without food, getting them in the body at the right time is also a priority. So that's sort of the advice that I've given.
Great, thank you. A question about how your adrenal insufficient patients have dealt with COVID.
Yes. So basically, we've approached it the same way we would any other illness, which is that we're looking at the patient in terms of, are they sick with it? So we've had patients call and they have a positive COVID test and they feel fine. In which case we just stay on guard, make sure that there's a good plan for stress dose steroids, but not necessarily do anything, because if the body isn't under stress, there's no fever, there's no vomiting, there's no no breathing problems, then we wouldn't give stress dose for that. We just stay on the regular maintenance plan with a low index of caution and suspicion to get in touch with us. And we've also advised patients to be vaccinated, so that if they were to become sick with COVID, they're less likely to become seriously ill. And that's we've approached it very similar to how we would approach the flu season.
Yeah, great. And Grace is asking, how do we get injectable hydrocortisone? I think she's referring to Solucortef. So if you want to shed some light there.
Yeah, so it's just a regular prescription at the pharmacy. Sometimes there can be local shortages, but right now we haven't, at least on the East Coast, been experiencing a shortage. And so it's prescribed, like I just sent it as a regular prescription. It also has to be prescribed with a needle and syringe to go with it. So and that's a separate prescription. Is there a
Well, and side note, always check when you pick up your prescription, because this happened to us, that it is the Acto vial. Because one time I picked up the prescription, got home and realized it was just the powder and no, solution. So that's just a little experience to share. Okay, and I just note you showed the medical bracelet. Brissa asked how to get that bracelet. Actually, the Raymond A. Wood Foundation created those bracelets with the help of the input of our neuroendocrine colleagues. So we do have them available on our website, and I think Jamie shared the link in the chat. Marcy asked, do you think it may be possible that lack of androgen replacement in adrenal insufficient females may contribute to weight, to gain of fat mass versus lean body mass during and after puberty?
So that's an interesting question. I don't think it would necessarily contribute to fat mass, but could it be a factor in like sort of less lean body mass or less muscle? It would be a small component of it. It wouldn't be the whole thing. But that's a great question. I don't have an answer or a study to reference off the top of my head. And I think that's why studies have taken place in this area, because, in terms of strength and bone health and all the other components, and looking at it. But again, the side effects of androgens, sort of unwanted secondary sexual hair, more than, growing hair, facial hair and things like that, as well as other changes that occurred. There were so many negatives to the ways that we've given back androgens in these clinical trials that the benefits really, weren't as notable as the downsides, but it might be an area, that in the future, if we had the right dosing, might be something to explore.
Okay. This is a good question. Why does it seem like some people with central AI are more brittle in terms of having more frequent crises versus others?
Yeah, and that's what that study out of Germany showed, that there was like a subset who are more, and I think even my patients, I could think of some who have had recurrent, with sort of very, what be a mild illness, really it hits them hard. It might be related to how quickly they're metabolizing cortisol. It might be related to other factors in terms of their body's normal inflammatory response. If you think about just your households, and a cold goes through the house and like one family member gets sicker than others, not necessarily related to anyone with a neuroendocrine problem, just different things hit different people. And so there might be people that are just more sensitive to illness in certain ways, or their body's inflammatory cascade kicks off in certain ways. There could also be differences in how much their absorption gets affected when they're sick. But it's not anyone's imagination. That is a real thing. And that lower index of suspicion, I have the patients of mine that are the ones who are most sensitive to this. Basically, I have parents that say, she just looked funny, so I gave her a stress dose. I hope that's okay. And for those parents who know their kid well, and a one-off stress dose at 2 a.m. when things looked a little bit unclear, and then, talking to me at 8 a.m. about how to plan the day, I trust the families. We sort of make a game plan for this to really aggressively head it off.
Great. And we have just a little bit more time for a few more questions. Okay. So how fast can an adrenal crisis happen? What does it really mean? Is it, and getting that stress dose in there, are we looking at 5 minutes, 30 minutes? What's the threshold?
There's no magic number. It depends on a lot of different things. It always appears to come on fast, but there's usually some signs that they're showing beforehand. But I think some triggers like vomiting can really hit hard and fast, whereas other things like brewing a fever might be, sort of this slow decline in terms of what's happening. So I don't have a certain number. When we think about it, when my patients' parents ask me about the school nurse and like, how are we going to do school and how's this going to look? They're not going to go to school well in the morning, and certainly like at 11:30 in the at lunchtime, a crisis is going to occur out of the blue. So generally the kids are going to have something going on. For patients that are, on the playground or running around and could fracture something, having the school nurse have a game plan to give an oral stress dose in the moment. If something like sudden like that were to occur, we always make that plan. But it generally, just like the way illness comes on, there's usually some subtle signs that something's happening before it becomes completely evident.
Okay. I'm going to do one more question. As Joy asked, my pharm class stated that steroids can affect the T4 being converted to T3. Is that, she says, how big is it? Should we change to T4, T3, or just T3 treatment?
So again, the physiologic, the daily dose is not going to be affecting this because our bodies are making cortisol. When the adrenal glands are functioning, our bodies are making cortisol every day. It's really used when we have somebody who has, the way it comes up clinically is for people who have Graves' disease. They have too much thyroid hormone being made from their own thyroid and we have to stop it. We use high dose of glucocorticoid to help. It doesn't stop it. It just one of the things we use to help that process. So we do use that as an approach, but in the daily doses, I wouldn't expect to see any effect of that. And even for 2 days of stress dose with levothyroxine being such a long-acting medication, I wouldn't expect to see much change even for stress dose. So it's really only in high dose of glucocorticoid that you'd see that phenomenon happen. And it would have to be high dose over time to make you start thinking about changing doses.
Okay. I have a couple that seem like they might be quick answers. Let's say, if a child is fine, but has a stomach ache or a touch of diarrhea, no fever or anything, stress dose or don't stress dose?
If it was my patient and they called me with this question, I would say keep a close eye. Make sure the kid's eating okay. If they're, when you think about diarrhea, you're really talking about like losing volume, enough fluid volume to make a significant amount of difference. And so I'd have a close eye, but I'd be ready for them to vomit. Again, and if it was 2 a.m, they'd given one stress dose and then called me in the morning, I'd say, well, just let's watch and wait. We don't have to continue the stress dose. That's probably how I would advise them in the real moment.
Okay. Heat. So a lot of our patients have temperature dysregulation issues and struggle in the heat. Do you adjust hydrocortisone for that? Or what are your thoughts there?
I probably wouldn't on a day-to-day basis. If it was like, if they were going out, like if it was field day at school and it was going to be really hot and I wouldn't necessarily give a stress dose, but would we consider giving like a little extra of the daily dose and see how the child does? Or maybe only I would do that if the child had a not so great time last time that happened and they really were distressed. But it's really that fine line of like, is the hydrocortisone going to make a difference? And it's a little bit of trial and error in those cases, because would an extra 5 milligrams of hydrocortisone that morning have led them to have a better day? Or is the heat just the heat and they're going to have temperature dysregulation no matter what we do?
Okay. Last question, because I didn't want to ask this because this does come up a lot. I see it a lot. My daughter is starting to get Cushing symptoms, the buffalo hump, skin discoloration, the moon face. Is it sign that her dose is too much?
So that's definitely something to think about, because the daily dose is really, again, for everyone whose adrenal is working, we shouldn't see any side effects. So if we're replacing the daily dose, matching what we should be making, we shouldn't see side effects. So the question is the dose itself more than what the child needs, or is the time of day the dose is given more than what the child needs? So that's something that is worth asking the prescriber about and figuring out, is there something we can tweak and change? And then the first thing that I would approach it with is that nighttime piece, because you really want to make sure you have that dip down really low while the child, like in the early part of the sleep period, and sort of seeing what time is the evening dose given and can we back it up, or and that's how I'd approach it if I saw things that were concerning for side effects. Or is this just the way the child's body is growing, and it has nothing to do with the hydrocortisone? But I would look at the doses, look at how much the child's on, and go from there.
Okay. Well, Dr. Topor, thank you so much for your time this evening and all of your insights and answering all of our questions. This is definitely a topic that is very often discussed, so we appreciate it. Thank you to Jamie Ping, our outreach coordinator, who helped moderate questions and pull this together. And thank you all for attending this evening and for your great questions. We will be announcing our conference, which will be coming up in November, our annual Pituitary Brain Tumor Family Conference, which will be virtual this year again, but hopefully in person next. Still a little bit wary of the COVID situation. So that will be coming up in November. So everyone be on the lookout for that. But thank you all very much, and have a good evening.